Thank you all for joining to hear about our recent clinical practice update on esophageal dysfunction due to disordered immunity and infection. My name is Sean Reddy. I'm excited to be joined by my co author, Dr. Emily McGowan. Dr. McGowan, why is it important for providers to be aware of infectious and immune mediated esophageal disorders?
Well, there are many different disorders that can lead to esophageal dysfunction, which is characterized by symptoms including dysphagia, adynophagia, chest pain, and heartburn. And these symptoms can be caused either by immune or infectious conditions, and they can either be localized to the esophagus or part of a larger systemic process. Unfortunately, though, because these conditions aren't as commonly seen and in many ways are poorly understood, they can be overlooked without having a high index of suspicion. And this can lead to a delay in the diagnosis and unnecessary procedures. So, with this clinical practice update, we wanted to help providers more readily recognize these conditions so that patients can be diagnosed and treated earlier in the course of their disease. Dr. Reddy, when should we be concerned about coexisting eosinophilic esophagitis in a patient with achalasia? And what would that workup look like?
Yes, achalasia and EOE might coexist more commonly than what gastroenterologists think, especially in younger patients. In a recent population based study, the estimated relative risk of EOE was over 30-fold higher in patients with achalasia 40 years of age or younger. In any suspected achalasia case, it would be wise to obtain biopsies throughout the entire esophagus when off confounding medications such as PPI therapy to establish if significant esophageal eosinophilia is coexistent. If EOE level eosinophilia is found, it would be reasonable to consider treating medically for EOE prior to committing to achalasia specific interventions, which often involve permanent disruption of the esophageal muscle layer.